Okay, hello everybody. We are doing the Module 4 exam review today. So let's get started. Let me go ahead and share my screen with you. And Module 4 is over our special populations, which includes OB-related emergencies, pediatric patients, geriatric patients, and other patients as well, other special challenging situations with some of your patients out there. Okay, so let's do this review. And it looks like it's just going to jump right into all the different presentations of the abnormal presentations of birth with the cephalic position. That's the head is coming out first, which is, the normal. And then we're going to proceed to go through all of this. Okay. All right. So let's start with the different types of birth. So your limb presentation, this is where you have basically an arm sticking out, right? When you do a quick look, you look to see that, unfortunately, you don't see the head, but you see one arm or one leg, okay? And that is sticking out. This is one of those presentations that we don't want labor to progress. It's because if it progresses, it's going to cause a lot of additional trauma to the mom and to the fetus. And so we really try to just rapidly transport them and get them to the hospital, where it's most likely going to have surgery or C-section, to remove this kiddo. So the limb presentation is a single arm or leg is what delivers first. But our treatment of this is we need to elevate the mom's hips, so elevate her pelvis. We need to cover that limb with a moist dressing because we don't want it to dry out, right? And we need to give our patient high flow O2. Okay, so give your patient high flow O2, elevate her hips, and cover that limb with moist dressing. We don't want her to push if that's at all possible, and then it's going to be a rapid transport to the hospital. Okay. Your next presentation is the breech birth. Now, breech birth is a little bit different than the limb presentation because the breech birth means that more of the fetus has come out. So the breech birth is when basically the rear end comes out first, the butt comes out first, okay? And if the delivery progresses, then we allow that to occur. We allow the butt and the legs to come out, okay? And if it progresses all the way and the head comes out, then that's fantastic, right? But sometimes with the breech birth, you're going to have the kiddo's body is outside of the birth canal, but the head is stuck inside, and that causes a problem, right? So you're going to have to, this is one of 2 times that you will be able to, or you're supposed to insert your gloved hand into the vagina to assist with either managing the fetus or sometimes with the rest of the birth. Because if you stick your hand in there and it makes enough room, she pushes and the head comes out, then there you go, right? But the breech birth, first thing is you want to make sure that you have the mother on high flow O2. That's an absolute, right? Anytime your mother is in active labor, she needs to be on high flow O2. And then for the head delivery, well, first thing, I want you to understand that the body is out, right? And if you think about the birth canal, the birth canal is really not that big, okay? And when you're squeezing this fetus through the birth canal and out into the world, then, their lungs are not able to expand or anything like that until they're actually outside of the mom. So breech birth, which is basically, backwards with the butt and the legs coming out first, if the body is outside, then the infant now or the newborn is going to start to breathe. And that's where the problem is because the head is still stuck inside mom. So this is the time that you're holding the baby, right? You're holding the body of the baby that's out. And just by holding them, you're stimulating them, and they're trying to breathe. Their lungs can expand, right? Their lungs are no longer compressed by the birthing canal. They can expand, and so they're going to try to breathe. But unfortunately, the head is still stuck inside, and the face, the head and the face is compressed up against the sides of the birth canal. So you're going to take your gloved hand and insert it into the vagina. You're going to find the face of the newborn, the face of the fetus that's still inside, right? And form a V with your index and your middle finger on their face, and you're basically providing a channel of air to come in from the outside into them, so they can breathe. Okay, so that's one of two times that we are inserting our gloved hand into the vagina. The second time that we do that is the prolapse cord, which just happens to be the next thing. Okay, so the prolapse cord is when you have the umbilical cord is presenting itself first. Okay, so you do a quick look. You don't see the head. You don't see any other part of the baby. You see the cord instead. Okay, so the cord is sticking out, and the problem with this is that the cord and the baby, they're sharing space in that birthing canal, which we already said is not very big, right? So the cord is actually compressed by the head of the fetus, which is cutting off oxygen to the little one, right? So our instructions to the mom is, please don't push. We don't want to push the umbilical cord back in. Okay, it's out. It's going to stay out. We're not going to try and push it back in. You want to elevate mom's hips. That's the first thing you do, is elevate mom's hips. Okay, and then you're going to insert your gloved hand into the vagina and basically just push the fetus's head off of the cord. So you're going to get the pressure of the head off the cord, and you're going to maintain that position, because if you let go, or if you remove your hand, then the head is going to compress the cord again. And remember, the umbilical cord is what delivers oxygen and blood and nutrients to the growing fetus, right? So if that's cut off, or if that's compressed or pinched, then that little one's not going to have any oxygen, and they're going to start to have severe distress, which we don't want. So you have to get the pressure of the head off the cord. Now, cephalic presentation, this is the normal presentation, right? This is actually, you do a quick look, you see crowning, it's the normal presentation, head's coming out first, and everything should progress as normal, right? And if you look at your skill drill 34-1, that is going to be the delivery of the newborn. So let me kind of pull this up for you. Come on, there we go. Go to your skill drills. We're going to chapter 34, which is down here. It should open you into a new tab for your JBO book. There we go. And here's your skill drill. So here's crowning, right? Cephalic presentation is crowning. We'll talk about other signs of imminent delivery a little bit later on, but the head's going to come out. Okay, when the head comes out, if we're able to go ahead and suction, then we do it. However, the head normally is faced posteriorly to mom, so it's kind of hard to actually see the face at that point. But you see how the provider is kind of grasping the head, one hand on each side. And what you do next is you guide the head down, so you can get that anterior shoulder. That first shoulder is going to pop out. And then after that shoulder pops out, you guide the head back up, so you can have that posterior shoulder. Once the shoulders are through, kiddo's going to come out, right? And then we're going to clamp the cord, in two places, cut the cord in between the two clamps, and start doing care for the newborn, right? Care for the newborn. Make sure make sure you got a good handle on them, because they're going to be pretty slippery. And once it's past those shoulders, there's nothing else holding that kid in, okay? And it's going to come out at you. So you really have to be ready for it. Go ahead and suction. Okay, we do suction the mouth first and then the nose. Because right now there's normally a big old glob of goo in the back of their throat, just from floating in that amniotic fluid for however so many months. And once we start to stimulate them, just by holding them, they're going to want to start to breathe, right? They're out of the birthing canal, they can breathe, and the stimulation is going to have them expanding their lungs and all that kind of stuff. So we don't want them to aspirate any of those secretions that they have in their mouth. So go ahead and use that bulb, right? Use that suction bulb that you have in your OB kit to suction the mouth, and then suction the nose. Okay, it says suction it gently with that bulb syringe. Okay, and then the cord itself, you got it. You clamp in between, or you clamp in two places. Okay, normally you want to clamp probably about 5 or 6 inches away from the infant. Okay, you don't want to have a big long piece of umbilical cord hanging there, but about 5 inches or so away from the infant, and then the second place is going to be about 2 or 3 inches away from that one. Okay, and then go ahead and cut in between. Always cut between the clamps, and then just leave it in mom, because the placenta is going to deliver on its own in just a little bit. But that way you're able to take the infant over to the side and do all of your normal management of a newborn, which we'll go over a little bit later. And the placenta, okay, her uterus, mom's uterus, is still contracting at this time. So the placenta will deliver normally about, it should deliver within about 15, 20 minutes, around there. Okay, everybody's different. So, just remember, it doesn't have to be exact, but it should deliver kind of on its own. She might say, oh, I feel like something else is coming. We'll take a look, and the placenta should be coming out. Do not ever pull on that umbilical cord, okay? The placenta will deliver on its own with the uterine contractions, okay? If you pull on the cord and you accidentally tear that placenta, then if there's any pieces of that placenta left up inside of the mother, then there's a very high probability that it can get infected, cause sepsis, and now we have a lot of problems. Okay, so just allow it to deliver on its own. So that's the cephalic presentation, which is the head. The nuchal cord. The head comes out, okay, but you see that the umbilical cord is actually wrapped around the neck of the infant, of the newborn, right? So super simple, nice and easy. Don't get all excited or anything like that. All you got to do is take your gloved hand, take one of your fingers, slip it underneath that cord, and then slip it over the head of the infant, or of the newborn, so it's no longer around their neck. Okay, very simple. Just stick your finger under the edge, right? Tip of the finger on the edge, and just get it off the neck, right? Slip it over the head so it's not around the neck anymore. Now, if for some reason this cord is tight, like it's too tight for you to be able to do that, then you may have to resort to clamping and then cutting the umbilical cord before the rest of the baby is out. However, if you do that, and remember, you have to clamp in 2 places and then cut between the 2 clamps. But if you do that, then just understand what you just did. You just cut off the oxygen supply to this kiddo, and the head is out, but the whole body is still inside that birth canal. They are not breathing right now. Okay, their body is compressed. They cannot expand their lungs. They're not breathing. So you have to get that kid out. The rest of the delivery has to proceed within the next couple of minutes. So there's no hypoxic injuries to that kiddo, okay, from the lack of oxygen, since we had to cut the cord. Let's see here. Amniotic. The amniotic sac is still intact. So this is something that can happen. Most of the time, though, like if if the water hasn't broken or something like that, sometimes the physician will go in and actually break the sac. Okay. But if, if you're on scene at a residence and it's time, it's imminent delivery, this is happening, and we're not going to make it to the hospital, then you're going to settle yourself in, get your scene and your area as sterile as possible using your OB kit, and then get ready for it. Now, if the head comes out and it still has, it doesn't, it looks like it's still encased in that sac, then you're going to have to burst or open that amniotic sac yourself. Okay. Super simple. You just kind of, you can rip it. That's not a big deal. Don't use your trauma shears or anything like that. That's way, not sterile, and we don't want to be cutting anywhere near the newborn, right? So you just kind of rip the bag. Be ready for all that amniotic fluid to come rushing out at you, because if it's still intact, then that means, quote unquote, her water hasn't broken. She has all of that fluid, still in that sac. So just kind of be ready for that. And then you just proceed with the delivery like normal, right? If it's not, hopefully it's the cephalic presentation, head comes first, and you just proceed with the delivery. All right. So it's kind of like, think of it this way. When we talk about putting the AED on your patient, if there's hair, you got to get the hair out of the way, and then you just put your pads on and keep going. This is the same thing, right? If the head comes out and the cord is wrapped around the neck, all right, not a big deal. We'll just slip the cord over the head and proceed with the rest of the delivery, right? If the head comes out and the sac is still intact, not a big deal. We'll just rip the sac, get ready for the fluid rush, and then continue with the rest of the delivery. Okay, so there's nothing really different about that. Okay, so we kind of already went over we did. We went over the step-by-step of that cephalic presentation with that skill drill. Please make sure you take a look at it, okay? It's 34-1, delivering the newborn. So take a look on your own, just as a review. But the way this works is there's actually 3 phases of active labor, okay? Or 3 phases of labor, and I want to make sure that I'm not getting way ahead. I want to make sure. I don't think it goes over these 3 phases. No, it doesn't. Okay. All right. So we're just going to go over it now. Okay. So the 3 phases. The first phase is what's called the dilation phase. Okay. And the dilation phase is going to be the longest phase. Okay, so the 3 stages or phases of delivery. 1 is the dilation phase, usually the longest, especially if this is their first. Then it can be quite long. The more pregnancies and births that a female has experienced, the faster labor goes. Okay, so that's another reason why it's really important to get the information of how many pregnancies have you had, and how many births have you had, and things like that, right? So the dilation phase, that's phase 1, and that begins with the onset of contractions, and it ends when the cervix is fully dilated. And remember, the cervix is going to dilate to approximately 10 centimeters. Now, we do not check the dilation, okay? And I want to make myself very clear on that, okay? You are not checking how much a female is dilated. That's not something that you're trained to do. That's not something that that is not within your scope of practice. That's not a pre-hospital thing at all, okay? But it's going to begin, the dilation phase begins with the onset of contractions. So when she starts having contractions, and it ends when the cervix is fully dilated. Now, the second phase is what's called the expulsion phase, okay? Not explosion, even though it kind of sometimes like that. It's the expulsion phase, and it begins when the fetus enters the birth canal, and it ends with the delivery of the newborn. And then the third phase, which is called your placental phase, it begins when the newborn is delivered, and it ends with the delivery of the placenta. Okay, so it kind of, those, back up to one another as different phases of delivery. Okay, and like we said before, the placenta normally will deliver about 15-20 minutes after the baby has come out. Okay, so those different phases will be, will the length of time are going to be different per patient. All right. They're all the same order and sequence, but as far as the length, it's all going to be different depending upon your patient. Okay. So, so when the baby comes out, right, like we said before with that skill drill, when the baby comes out, you are holding, right? You're holding the kid, making sure that the kid doesn't, doesn't get dropped. We don't want that, right? We want to keep them warm, okay? Because this kiddo, just remember, this kiddo just came out from a 98.6 degrees, right? That's our normal body temperature. So this little baby has been swimming for the last however so many months, right? 9-10 months, and in 98.6 degrees, and they come out into the ambient temperature, the ambient room temperature. And if you're in the back of the ambulance or if you're in someone's home, then it's probably in the 70s or something like that, depending upon what temperature they may keep their home in. But it's cold. They get cold and they don't know how to thermoregulate yet. Their bodies are not able to do that. So we have to keep them warm. Okay. They're going to lose that body heat very quickly. So we have to keep them warm. You can do that multiple ways. You can have skin to skin contact with the mother. That is one of the best ways to keep this kiddo warm, right? Is to hand out, if everything is okay and there's no need to manage airway or anything like that, then, sometimes we can just hand the kiddo over to the mom for skin to skin contact. Use blankets, obviously, to keep them warm. But the first thing we should do is we should dry off the newborn, okay? Because when they first come out, they're going to be covered in that, oh gosh, what is it called? Vernix. They're going to be covered in the vernix, which is that like white substance. Okay, that lighter color white substance. This is going to sound gross, and my apologies, but it's almost like if you like smeared cream cheese on your skin. That's what it's like. It's like a thin layer of that, and that is in place. That vernix is in place to protect the developing skin of the fetus while they're in that amniotic fluid. So there's no breakdown of the skin while they're in that fluid for so long. So when they first come out, they're gonna be covered in that, right? And they're gonna have the fluid and all that kind of stuff. So we need to dry them off. That's step one, right? Dry them off, and then start to keep them warm. As we are drying them, we are stimulating them, okay? And that's going to help them breathe and all that kind of stuff. So dry them off, wrap them in a blanket, hand them over to mom, okay? This is going to sound weird, but you could also use, if it's really cold and you're worried about hypothermia with this kiddo, you're really worried about heat loss, then you can actually this is going to sound really weird, but you can put your baby in a bag, okay? You can put your baby in a bag. They have little plastic bags that come in your OB kit. And if you don't have one of those, you have biohazard bags. You have bags on your ambulance, okay? And if you just now I'm not talking about putting their head in there, but wrap them in a blanket, and then just like ease the body of the newborn into that bag. Keep the head out, but that won't hold the warmth in, right? And before you guys, start thinking, wow, Stephanie, you're crazy, I want you to think about something. When it's wintertime here in Texas or anywhere, and that wind blows and it is cold, you lose heat if you don't have a good barrier, right? So if you have just a blanket wrapped around you, that wind is going to cut right through you, right? But if you have that windbreaker that has some sort of like a plasticky material or something that's a much better barrier, then it helps you to keep your heat inside your jacket, right? And that's basically what we're doing here. So as long as you're able to maintain the heat and not allow a lot of heat loss, that's the most important piece. So the baby comes out, we're going to dry him off using our blankets. Make sure that you wrap them in a clean and dry blanket. Don't wrap them in the blanket that you used to dry them off with, right? Because that's wet and that'll just make them more cold. And then you can hand them to mom. Okay, so we want to keep them warm. We also want to, be very careful of their airway because their heads are exponentially larger than their body, and their neck muscles are not developed to where they cannot hold up their head. So we really need to, keep that airway in a neutral position. Okay. Go ahead and suction the airway if needed, just like we were showing on that skill drill, okay? Because they do sometimes have secretions and stuff in their mouth from being in that amniotic fluid. So suction the mouth, suction the nose, okay? And then if your patient is not as lively as what we want, and we'll talk about the APGAR score in just a moment, then you need to stimulate them. We can rub their back, flick their feet. Okay, they're very, very sensitive to that. So, but stimulating them by rubbing their back will also help, and it helps to warm them as well. Okay. Now the placenta is going to deliver. It might not deliver until you get to the hospital, and if that's the case, then you don't have to worry about it, right? But after you've clamped off and cut that cord, then again you're taking the baby to the side and you're managing the kiddo while another provider is managing the mom, because we'll talk about the post delivery care of mom in just a moment. But that placenta is going to deliver on its own. If it does deliver while you still have the patient with you, then you need to keep it and give it to the ER physician when you get to the hospital. So use that biohazard bag. You should have several of them on your ambulance. Put it in the biohazard bag and, make sure that it gets transferred over to the physician so they can inspect it and make sure, everything is intact. Okay. Now the care for the mom, so the post-delivery care for the mother normally deals with hemorrhage control, right? So if she has that post-delivery hemorrhage, we worry about when it's more than half a liter of blood. That's our worry. So if it looks like mom's just bleeding a lot and it's not stopping, then we need to use the uterus to help contract and help with stopping that blood loss. And the number one way to do this is to do a fundal massage, Fundal, fundal massage. And that's where you, on the outside, right, on kind of the lower stomach, you want to, you're pushing and you're massaging in a circular motion. You're kind of pushing down hard and massaging in a circular motion, and that's the fundal massage. We're massaging the fundus of the uterus, and by doing that, we're also we're hoping that the uterus is going to continue to contract and assist with that blood loss. You will definitely give your mother oxygen, right? High flow O2. And then we don't pack the vagina. It's another cavity, we don't pack that. So you'll just kind of cover the vaginal opening with sterile pads to, or bulky trauma dressings, just kind of cover the opening to catch any of the blood or absorb the blood. Do that fundal massage and rapid transport. Now, if the baby is okay and if mom is okay, then you can see if the newborn can start to breastfeed, because that will actually help with post-delivery hemorrhage with the mother as well, because of the release of hormones and things like that. It'll really help with that. So there's multiple ways to do it, but remember, don't pack the vagina. Put those pads on the outside and do that fundal massage, definitely. And if you're able to, then get the newborn to breastfeed, or see if the mom can breastfeed. Okay. All right. So what are some signs and symptoms when you determine whether this is a low and go situation? Because whether it's an abnormal presentation and we need to get to the hospital, or we have some time before delivery occurs and we still need to get to the hospital, things like that. Or this is a stay and play. Stay and play is going to be, we're staying on scene because this is happening, right? So let's talk about the signs of impending delivery. Okay. So the signs of impending delivery is going to be your female says that she feels the need to push, right? That's one sign. If the mom says, yep, it's coming, that sounds silly, but that's another sign. If she says she needs to have a bowel movement, that is a sign of imminent delivery. And imminent delivery means it's coming, right? It's on its way. This is started. Because if she says she has to have a bowel movement, then that means that the baby's head has already dropped into the birthing canal. And that birthing canal, when the baby's head is down in there, it's compressing on her colon, on her large intestine, and it feels like she needs to have a bowel movement, which is why there's so many times that sometimes pre-hospital people will actually give birth in the bathroom because they felt like they just needed to go to the bathroom, right? They just felt like they needed to go have a bowel movement. So they go and end up actually giving birth in the bathroom. Okay. So if she says, I feel like I need to have a bowel movement, first off, do not let her go to the bathroom. That's a sign of imminent delivery. So do a quick look. If you see her crowning, that's a sign of imminent delivery. The crowning, if the head is there, right? And then the contractions themselves. Remember, the dilation phase starts with the onset of contractions, and that dilation phase can be several hours or days, depending upon how many pregnancies she's had. But the contractions themselves, those are the uterine contractions. The uterus is, starting to, get ready to get that baby out, right? So the more intense the contractions get, the longer they are, and the more frequent they are. Okay. So the longer they are, the more frequent they are. So the closer they are together, and the more intense in pain. That's gonna tell you that you have imminent delivery. Okay. So if she feels the need to push, if she says this is happening, we're about to deliver, if she says I need to have a bowel movement, if you do a quick look and she's crowning, or those contractions are really close together, very intense and very frequent, right? Those are your signs of staying in plane. You're not going to be able to make it to the hospital. Now, if she doesn't have those, then we're going to go ahead and, we don't need to hang around. We can go ahead and transport. If she, if you do a quick look and there's a limb presentation, remember, that's a rapid transport, right? Limb presentation is when the arm or the leg is out first. You elevate mom's hips, give her some high flow O2, cover that limb with a moist dressing, and rapid transport to the hospital, right? If there's the prolapsed cord, right? If you do a quick look and that umbilical cord is out, then you instruct the mother not to push. Put her in that elevated hips position. Insert your gloved hand to get the fetus's head, the compressing head, off the cord, and then it's rapid transport, right? You maintain that position. So there's definitely different times. And then again, the breech birth, if the body is out first and the head hasn't delivered, then give your mom oxygen, right? Make the V with your gloved hands. Insert them into the vagina to prevent compression on the baby's face, right? You put it across the baby's face because at this point, the newborn is trying to breathe, right? So those are all going to be load and go situations. If there's an abnormal presentation or some like a stalling of the of the actual labor itself, and it won't progress any further, then this is a load and go. Okay. All right, the process of reproduction from fertilization to delivery, where each stage. Okay, so we kind of talked about this in class already, but remember, when the ovary, a female has two ovaries, one in her left lower quadrant, one in her right lower quadrant, and every 28 days, your female patient is going to release an egg from one or the other, right? She doesn't, well, you could have two, you could have three, it just depends. But normally it's just one egg. And it's going to go into that fallopian tube. follow the pathway of the fallopian tube into the uterus. Now, if fertilization does not occur, then all of the tissues and all that padding, basically, excess tissues that have been building up over the last couple of weeks will be shed during her menstrual cycle, because there is no fertilized egg, right? So the body recognizes that this fertilization didn't occur, so the menstrual cycle will continue, and the egg and the all the excess tissue that's been building up, that will be shed. Okay, she'll be on her period, right? But if fertilization does occur, and the normal place where fertilization occurs is in that fallopian tube, if it does occur, and then it continues down and it implants itself into the side of the uterus on that nice cushiony surface that's been built up, then that's great, right? Then the process of this embryo is going to start to grow, and it's in the right place, right? We want it to be in the uterus, and we'll talk a little bit later about other emergencies and things like that. But we want it to be in the uterus, so the uterus can grow along with the embryo and provide a suitable environment for the growing embryo. Okay, that embryo will be in there for 9 to 10 months, right? Approximately 39, 40 weeks. I believe 39 is full term, maybe 36. I can't remember. Anyway, around there, and your patient, and then, labor happens, right? Dilation phase occurs, expulsion phase occurs, and then placental phase, right? So fertilization happens in the fallopian tube. It implants in the uterus, where it will continue to grow, and then labor occurs. So some of the questions that we have to ask is gravida, para, and abortions. Okay, so when you have your pregnant patient, we need to know her history, right? Not just her medical history, as far as, do you have any history of high blood pressure? Do you have any diabetes or anything like that? We need to know if she's been pregnant before, because that's gonna make a difference, because her body is different than someone who's never been pregnant before, right? Or this is their first pregnancy. First pregnancy, they haven't experienced all those hormones yet, all that kind of stuff, and their body is going through everything the first time. Excuse me. If someone has been pregnant before, and been in active labor and given birth before, then their body is familiar with that. And so some things, the delivery is normally a little bit quicker, right? So gravida, para, and abortion. So GPA, all right? So gravida is the total number of pregnancies that your patient has experienced. Para is the number of live births. And abortion is whether it is a spontaneous abortion, which is what we call a miscarriage, or it is an intended, abortion, right? But that's where the fetus is either lost with a miscarriage and expelled from the body before the 20 weeks. It's always before 20 weeks, okay? But gravida is the number of pregnancies, para is the number of live births, and then abortions or miscarriages are, fetuses that don't make it to term. Okay, that's the easiest way to explain it. Don't forget that gravida is always going to be higher than the rest, right? Because if I, like, for example, I am not pregnant right now, and I only have one kiddo. So my gravida para is gravida 1, para 1, because I've been pregnant once and I have one live child. But if I was pregnant for the second time, then I'm going to be gravida 2, para 1. Okay. If your patient is, if this is her 5th pregnancy and she has 3 live kids and had 1 miscarriage, then that's gravida 5, para 3, abortion 1. Okay. So you really need to ask your questions and make sure that you know what the GPA is. Okay. Okay. Now, before we get into some of these other emergencies, I really want to go over some of the changes that the mother's body goes through during pregnancy, because I don't think that's in here. Previous exam reviews. I don't really go through all of this. I go through. Hang on. Oh, no, never mind. Okay. Never mind. We're going to talk about that a little bit later on. So we'll just get back to that a little bit later. So now let's talk about some specific OB emergencies that occur. These are going to be on your purple chart. I highly, highly recommend that you guys know that purple chart and the signs and symptoms and all this stuff that I'm about to talk about, okay? So eclampsia. Well, first off, I want to talk about preeclampsia first, because it makes sense more to talk about preeclampsia before eclampsia. So preeclampsia is actually pregnancy-induced high blood pressure, okay? So that means she doesn't have high blood pressure from previous, this isn't part of her medical history. Preeclampsia is actually the blood pressure is affected by the pregnancy. So pregnancy-induced high blood pressure, and the hypertension is going to be greater than 140/90. Okay. Now, during this time, and this is an emergency, okay? During this time, your patient is going to be complaining of headache. She might have some altered mental status, blurry vision, and generalized swelling of the face, hands, lower legs, and feet. Okay. And when I say swelling, because this is important, a lot of pregnant patients, their feet swell and things like that. That's normal. This kind of swelling is going to be a noticeable thing that comes over, like, yesterday I was fine, and today, my feet are massive, that kind of thing. And her face is all swollen and her hands are swollen. She's just puffy. Those are symptoms of preeclampsia. Okay, so this pregnancy-induced hypertension that causes possible altered mental status, most likely a headache, blurry vision, generalized swelling of the face, hands, lower legs, and feet. This preeclampsia is normally seen in the 3rd trimester. Okay. Now, what do we do for that? How do we treat that? The first thing is the recognition of it, and then transport to the hospital. We need to keep her calm, though, because we don't want any stress or anxiety to add to the situation and possibly increase her blood pressure even more, and then send her into the next phase of this, which would be eclampsia. And eclampsia is going to have all the same signs and symptoms as preeclampsia, except now your patient will have seizures as well. Okay, eclampsia is definitely more severe than preeclampsia because it's further along in the process of that pregnancy-induced high blood pressure, and she's having seizures, right? And again, preeclampsia and eclampsia, these are going to be in your 3rd trimester. So what do we do? ABC management, rapid transport to the hospital, oxygen administration if needed, and making sure that your radio report to the hospital is thorough enough that they know what's going on, right? So one of the things you might want to be careful of, though, is if you go lights and sirens to the hospital, that actually might aggravate your patient more. So if she's preeclamptic, then maybe you don't. And this is just me, every situation is different, but you don't want an emergent transport with lights and sirens to add to the stress and then send your patient into a seizure, into eclampsia. So just kind of be careful with that. Placenta previa. So placenta previa is when the placenta actually develops over, either partially or completely over the cervical opening. Okay. The signs and symptoms of placenta previa is your patient is going to be experiencing bright red vaginal bleeding that is painless. And this normally occurs in early labor. All right. So it's going to be later on in the pregnancy. Now, let me show you some pictures here to make sure we are on board with what we've got. Placenta previa. Okay. This is a great one right here. So here's the uterus, right? Here's the uterus. Fetus is growing. Okay, here's the placenta. The placenta is what, when it initially, when the fertilized egg initially attaches in the uterus, if it attaches low on the uterus, remember we said, the fallopian tube is over here. It's going to follow the fallopian tube and attach somewhere in the uterus. We want it to attach kind of in the upper half if possible. If it's lower, and especially really low to that cervical opening, then when that placenta grows as the embryo is growing, then yes, this placenta right here is going to completely cover that cervical opening. And if you remember our 3 stages of labor, we have dilation, expulsion, and then placenta. The placental phase, the delivery of the placenta, should always be last, right? Always be last. So if this is blocking the birth canal, because the cervix, that's the opening to the birth canal. This is what dilates to that 10 centimeters, right? And then the rest of the birthing canal. If that's the case, placenta previa, then during the early signs of labor, as this cervix is starting to dilate, the placenta right here is going to start to bleed, okay? And that's why you see that bright red vaginal bleeding. But it's painless because it's the placenta that's bleeding and it's not the mom, okay? And we'll talk about that with abruptio placenta. It's a little bit different, okay? So the blood loss is actually not, it's not from mom per se. So she's not going to be shocky or things like that. You won't be seeing cool and clammy and signs of shock. But it is definitely a sign of distress because it's coming from the fetus, and we don't want this placenta to come out first. If this placenta comes out first, then that's going to cause all kinds of problems. So placenta previa, if you have a patient who has been experiencing or been going to their doctor, right, and had prenatal care, then that's fantastic. That's what we want, right? And if their doctor finds that they have placenta previa, then this kiddo cannot be born by a vaginal birth. It's just not going to happen. It's not physically capable of that. So this kiddo is going to be born by C-section. Okay, so this is the normal placement, right? We want it kind of on the upper part, so it's away. And also, it helps with, the umbilical cord not being wrapped around the kiddo or coming out first or anything like that. A little bit, the lower the placenta is, the more likely the cord is closer to that cervical opening. So we want it higher up. But the head comes out first. That's what we want. This one with placenta previa, it's blocking that cervical opening. It's blocking the birth canal. It's not going to happen. So this is going to be a C-section. But if your patient is experiencing painless, bright red bleeding, and is painless to her, and she's like, no, and it doesn't hurt, then that's placenta previa. Okay. The next one on your list is placenta abruptio, or abruptio placenta. Okay. So abruptio placenta, this is when the placenta separates prematurely from the uterine wall. This will be painful. It's actually quite painful. Your patient will be experiencing severe pain, and they're basically going to be telling you it feels like it feels like there's a tearing sensation inside of them. Okay. And when this occurs, your patient is losing blood volume. And so your patient will have signs of shock. So on abruptio placenta, okay, then this is a really good, I'm pretty sure this is a really good picture. Okay. So here's, this one on the left, this is normal. Here's your placenta. Everything's good. Everything looks good. Cervix, birth canal, everything looks good. Here, it's tearing, right? So these two are your abruptio placenta. So it's starting to tear off of the uterine wall. And the blood's coming from mom, and you do see the hemorrhage. Actually, you actually see the vaginal bleeding. The bleeding will come out, okay? This one is also abruptio placenta, but the tear is more towards the top or the superior part of the placenta, and the inferior part is still intact. It's still on the wall. So this hemorrhage is concealed. So she doesn't have any vaginal bleeding, right? But she's still going to be experiencing the tearing pain, the severe pain, and she's going to be showing signs of shock. So cool, clammy skin, tachycardia, possible hypotension, all that kind of stuff. Okay. So abruptio placenta is, it can lead to hypovolemic shock because we have internal bleeding from that placenta tearing away from the uterine wall. Now, this is normally after some kind of traumatic event. Okay, and abruptio placenta can occur up to 72 hours after a traumatic event. So if you run a car wreck and there's a pregnant patient, and this is normally a third trimester, later on in the pregnancy kind of thing, right? Placenta previa is going to be third trimester because we have early labor, things like that. But abruptio placenta, her belly is going to be, pretty big, right? And if she's in an MVA and she's standing up, walking around saying, no, I'm fine, I'm fine, I'm fine, be that patient advocate and say, hey, I really want to get you taken to the hospital. I really want to transport you to the hospital just so a physician can check you and your baby and make sure everything is okay. And you can even tell them, hey, things can happen. There are things that could happen over the next couple of days from this traumatic event today. So if they refuse and they don't want to go to the hospital, remember, you can't make them, right? If they're alert and oriented and able to make decisions, you can't force them to go, but you definitely need to be that patient advocate that says, all right, look, really pay attention. And if you start to feel bad, if you start to feel dizzy, if you have any spotting or vaginal bleeding, or anything, any pain, any abdominal pain, call us back immediately, or go to the ER. Right, because we don't want this to be a problem. So the abruptio placenta is painful vaginal bleeding. You may or may not see based upon the location of the tear, but your patient, your mother, will be showing signs of shock. This is another really great picture because it shows some separation right here. Okay, kind of on the inferior side, so the blood is able to come out and we see visible bleeding. Separations kind of on the side and the blood's able to come out and still kind of intact in the middle. But if it's completely, if it's basically you can't see it, then the hemorrhage is concealed and she's not going to have bleeding, right? But she'll have all the other signs and symptoms. Okay. So that's your placenta previa and your abruptio placenta. A spontaneous abortion, that's the miscarriage. Okay. Spontaneous abortion, that's the miscarriage. And this is a loss of pregnancy prior to 20 weeks of gestation. Something happens. A lot of times we don't know why, but something happens and the body aborts the fetus. So it's a spontaneous abortion. By the body, your patient is going to be experiencing severe abdominal pain and cramping, and of course vaginal bleeding. There may be passing of tissues with the blood as well, but the biggest sign and symptom of a miscarriage is that abdominal cramping. Okay. Now meconium is not necessarily an emergency with the mom. This is more of an emergency with the fetus. Okay, so meconium staining, that means that the fetus was in distress at some point while they were still in utero, while they were still inside mom. Okay, and that can be a problem. So meconium itself, meconium is basically the baby's first bowel movement. Okay, that is what meconium is. It's a sticky, thick, dark green, blackish substance, which is normal for all babies. Okay, all newborns will have meconium because this is their, their body's first, it's their first digesting things and, and all that kind of stuff. And it's just different, right? So meconium is a thick green, sticky, tarry kind of substance, which is the newborn's first poop or first bowel movement. But if it happens while the fetus is still inside mom, that's the problem. Okay, that's the sign of fetal distress, but that's a problem because the fetus can aspirate this substance into their lungs, and it can clog up their airways because it's so thick and sticky. Okay, so let's take a look real quick. Remember when I said that green is my favorite color, right? But whenever it comes out of your body, it's not a good thing. Because we had green, greenish mucus and sputum and all that kind of stuff with our patients that were experiencing pneumonia. Well, if you've got green on the newborn, what am I trying to do? Meconium, or just meconium, that'll work. Okay. So if you've got this greenish tarry black stuff, which like I said, that's normal when they're out. So the first, when you guys become parents, and if some of you already are parents, some of the very first diapers that your newborn has, their stool looks like this, right? It's definitely interesting to see. And then as you start using formula, or hopefully you're able to have some, the nursing, right? Then with breast milk, then the stool changes. Okay, but this is the first stool. Now, here's the problem. In utero, if this occurs, then that mixes with all that amniotic fluid, and it can get into the baby's airway. That's the problem. Okay, it can get into the baby's airway, get into their, really get down into their bronchi and bronchioles, right? It can get down in there, and it can get really, really sticky, clog up these airways, and cause a lot of problems. Lots of problems. Okay. If you notice the color of this fetus versus the color of this one has kind of a cyanotic look to it, and that's because this kiddo is in some kind of distress. And fetal distress can come from multiple things, right? It can come from trauma to the mom. It can come from prolonged delivery that hasn't really been progressing very well, right? Like maybe the kid gets stuck or something like that. It can come from multiple things. It can come from eclampsia, right? Preeclampsia and eclampsia, and multiple things. But if this kiddo comes out and they've got kind of this greenish stuff on them, then that's a problem. And then you will need to do some suctioning. Okay, you'll remember we talked about suctioning the airway. You'll definitely need to suction the airway. Okay, you kind of see some of that green on that little guy right there. Okay, they're using different suctions. Obviously, they're in the hospital, but you're going to use that bulb syringe to really suction the airway and make sure that airway is clear. And then you also want to make sure that you report this information to the hospital staff, right? The physician and the hospital staff, that there was meconium staining when the baby was first delivered, because they are going to go in and then they're going to use this little meconium aspirator. Basically, they're going to intubate that kid right then and there, and suction, like do a deep suction of their lungs and make sure that there's nothing left inside that's going to cause infection or do any kind of problems to that newborn. So anytime you see that greenish tinged substance on the surface of your kiddo when they first come out, aggressively suction the airway, make sure that the airway is as clear as possible. If your patient is not doing very well and needs more airway management, needs to be, assisted with their ventilations, then we'll do that. We'll talk about that in a minute, but, it's all about airway management, and then make sure that the physician and the staff at the hospital know what happened. So that's meconium staining. Now, ectopic pregnancy, which I know we've discussed this in class, and some of you guys have done some scenarios, but I know we've discussed it at least in a case study. But an ectopic pregnancy, this is where the fertilized egg has implanted itself somewhere other than the uterus, right? An ectopic pregnancy, it is a life-threatening thing, and that embryo is now starting to develop outside of the uterus. The most common position is, or the most commonly found place of an ectopic pregnancy is the fallopian tube. Okay. And the tissue surrounding that growing embryo can't, it can't, maintain the growth of that embryo. So the tissue will rupture at some point. So your patient is going to be experiencing kind of a dull pain in the beginning, and it's just going to continue to get worse and worse and worse and worse until hopefully, she calls us or goes to the hospital and unfortunately is most likely going to be surgically removed, or unfortunately, if it ruptures. And if it ruptures, then she's going to have signs of shock. Okay, she's going to be cool and clammy with signs of shock. Okay, so tachycardia, hypotension, that kind of thing. And ectopic pregnancy, remember, this is a first trimester emergency. Your placenta previa, ruptio placenta are normally in the latter part of your pregnancy. Your eclampsia and preeclampsia are in your third trimester, are absolutely in your third. And then your ectopic is in your first. Okay. All right. Ectopic pregnancy has that high rate of mortality. If it's not identified, we need to, get them to the hospital, because unfortunately it's going to be surgery. You can also have a patient, I'm just going to throw this in here, a ruptured uterus. Okay, we'll talk about that real quick. This is where the uterus ruptures, and we've talked about the word rupture enough in class. I think y'all should be familiar with that. But this is where the uterus ruptures, so it bursts, right? And it actually releases the fetus into the abdominal cavity. Most of the time, this will occur because maybe the mom has a history of previous ruptures. Maybe there's a history of abdominal trauma. It's very possible that she has had a very prolonged and difficult labor where she's pushing and pushing and pushing and pushing, and it's not really progressing. Okay, and then the more births that a female has had, I don't want to say the more likely, because it's not that common, but yeah, I guess the more likely that it could happen. Okay, there's obviously going to be severe maternal hemorrhaging. She's going to have to go straight to surgery because there's a very, very high mortality rate with this. Now, another thing to remember is the fetus, remember, is directly affected by the mother. And so when the mother is hemorrhaging, if the fetus is still, inside, so this is not going to be a post-delivery hemorrhage. This is going to be when she's still pregnant. If the fetus is still inside and mom is hemorrhaging, then that means the fetus is hypoxic and not perfusing very well, right? Because if she's losing blood volume, then her blood volume is being taken away from the fetus. Maternal seizures also lead to fetal hypoxia. So if mom is having a seizure, like in eclampsia, it leads to fetal distress and hypoxia. Okay, so all that, it's all, we're all connected, okay? The number one cause of fetal death is maternal death. So if you have a pregnant patient and they're experiencing one of these emergencies, and we're not in active labor or anything like that, but they're experiencing one of these emergencies, then aggressive ABC management and making sure that they're oxygenated, right? We're assisting ventilations if we need to. If this is unfortunately cardiac arrest, then you are doing, your compressions and your ventilations. You're putting your AED on your patient. You're following all those protocols and all the skills and things that we've talked about, because in order to keep that fetus alive, we have to keep the mom alive. Okay. All right. Signs and symptoms of adequate versus inadequate breathing for an infant. So for your kids. All right. Let's see here. Oh, what do I have? All right. So signs of adequate breathing for your infant, obviously, is if they have good respiratory rates, correct? And for children, normal respiratory rates are going to be between 12 and 40, infants 30 up to 60, right? Because if we were doing rescue breathing for a child or an infant, then we are doing one breath every 2 to 3 seconds, right? So those kiddos, they inherently breathe faster than an adult does. So they have a normal respiratory rate. They have a good pattern of inspiration versus expiration, right? It's a 1-to-1 pattern of in and out. They have good tidal volume with equal chest rise and fall. They have good breath sounds bilaterally, and they have good skin color. Okay, so all of that is should sound pretty familiar from when we talked about respiratory distress and respiratory failure at the very, very beginning of the course. So they've got a good rate, a good tidal volume, good skin color, right? And we've got, good breath sounds. Now, as far as mental status is different for kids. They can't talk to us all the time and answer all of our questions. So how are they behaving? Sometimes you have to get the family involved and, is this normal for them? Are they normally kind of fussy like this? Or, that kind of stuff, right? So look at the mental status. Signs of inadequate breathing are going to be abnormal noises. Okay, grunting is a big one. If you hear your kiddo, if your kiddo looks like they're in respiratory distress and you hear grunting, then that's a problem. Then that means they're really not having a lot of gas exchange. If there is accessory muscle use and those retractions that we've seen before, right? Where they're engaging additional muscles. If they have anxiety, restlessness, or they're combative, okay, those are all signs of hypoxia. If they have head bobbing with their respirations, so each time they breathe, their head is bobbing up and down, okay? Nasal flaring, if their nose, their nares kind of flare out, those are actually signs of distress. Tachypnea, of course, right? Elevated respiratory rate. If your kiddo is old enough to place themselves in the tripod position. And then one of the things that I hope you guys have learned from either reading in your book or from scenarios and us talking to you is your kids, they compensate very well until they don't anymore. And so their rate of deterioration is it's good until it's like it just falls off a cliff and they're not good anymore. There's no gradual deterioration. Okay, so there's going to be a rapid change when they deteriorate, or if they deteriorate. So watch for that tachycardia and that tachypnea to change rather rapidly to bradycardia due to hypoxia, right? Because remember, hypoxia is the leading cause of bradycardia in kids. Okay. So the APGAR score, this is the score that we use to assess our newborn. And we do it at 1 minute postpartum and then 5 minutes postpartum, okay? So let's talk about the APGAR itself, okay, the APGAR score itself. So APGAR is 5 things. You have appearance, pulse, grimace, activity, and respirations, okay? And let's see here. Let me find you a good picture of the APGAR score. Is it this one that I like? Yeah, that's a good one. Okay. Appearance, pulse, grimace, activity, and respirations. Perfect. Okay, so this is similar to your GCS, right? But this is for a newborn because GCS, they can't talk. A newborn can't talk to us. They're going to respond differently, right? So in a GCS, remember the lowest is 3 and the highest is 15. In APGAR, the lowest is 0 and the highest is 10. Okay, so just don't get those confused. So for appearance, each one of these, there's 5 different categories. Each one of them is going to have either 0, 1, or 2. So for appearance, 0 is going to be if your patient is completely cyanotic, extremities and core. 1 is going to be the core is pink, but the extremities are cyanotic. And this is actually okay, because if you think about, that birthing canal, it's not very big, and this kiddo just got squeezed through that birthing canal, it's going to take a minute or two for the blood to kind of, get back out to the extremities once they're out. Okay, so if you have a score of a 1 on appearance, don't worry too much. Hopefully they'll come all the way pink pretty soon. If they come out all the way pink, right, core and extremities, then that's perfect. You got a score of a 2. The pulse, this is the only one that has a number related to it. 0 is going to be no pulse at all. or pulseless, right? 1 is less than 100 beats per minute, and 2 is over 100 beats per minute for the pulse of that newborn. G stands for grimace. Okay, grimace, 0 is going to be no response to any kind of stimulation that you do. And remember, you're stimulating this kid, right? You're rubbing on them, you're flicking their feet, you're wanting them to cry and breathe and all that kind of stuff, right? If they're not doing it on their own very well, then you're stimulating them to do it. Okay, so a 0 is going to be no response to that stimulation. A 1 is like a minimal response or kind of a weak cry. And a 2 is that strong cry and strong movement with your stimulation. They're trying to pull away from you, and that's a good thing. A stands for activity. 0, unfortunately, your patient is completely limp. There's no movement. They're floppy, they're flaccid, they're completely limp. A 1 is they're going to have a weak resistance to the extension of their extremities, okay? So their arms and legs are going to be somewhat flexed, kind of a weak resistance. And I know I've said this in some of the classes already, but if you think about when a kid is born, they get weighed and they get measured to see how much they weigh and how big or how long they are, right? And it's always in centimeters, right? How many centimeters? So this kiddo is being taken over to a table. Of course, it's underneath a warm light or like a heat lamp, to keep them warm. But they're trying to straighten out their legs and their arms to see how long the kiddo is, right? So if they're completely flaccid, then that's a 0, right? If they're like weakly resisting to you trying to straighten their arms, then that's a 1. And if they're really strong and they're very active and they have that strong resistance to you trying to, straighten out their legs, then that's a 2. And just remember that fetal position that we've seen in some of our other pictures, that's how your kiddo has been, right, the entire time. Most of the time, they don't have a whole lot of room to stretch in there, right, in the uterus. So a lot of times the legs, are bent up into the core, and the arms are in that what we call that fetal position. So the active movement, resistance to you trying to extend their legs, that's a 2. And then respirations is our last one. Okay, you notice there's no number here. The only number is on pulse. So respirations, 0 is they are apneic. Right? Absent respirations or apneic. A 1 is going to be slow and irregular respirations. And a 2, if you look, we don't do it based on respirations. We do it based upon their cry. So if they have a vigorous and strong cry, then that's a 2 for respirations. That's a good thing. Okay. Whenever if you get called to an OB emergency and the birth occurs before you get there, and you walk in and you hear a baby crying, that's a beautiful sound. That's what you want to hear, right? If you walk in and it's quiet, then that's a problem, okay? Because we want this kiddo to be crying because that means they're breathing. Okay, so this APGAR score is done at 1 minute postpartum and then repeated at 5 minutes. So if they are somewhat lower, then we're hoping that, at that 1 minute mark, then we're hoping at that 5 minute mark, after us stimulating them and rubbing on them and drying them off and suctioning and stuff like that, then they're going to be a lot better. So let's talk about the actual numbers and the scoring and what do we do based upon their APGAR score, okay? So it's performed at 1 minute and 5 minutes postpartum. We talked about, the actual point system and what each different thing means. And then let's think about, the actual scores. So 0 to 3, that's going to be your worst, right? Because 0 is the lowest. If your patient has a 0 up to 3 on the APGAR score, then you're going to have to do some aggressive management. Okay, you're definitely going to have to do some aggressive management. You're going to have to provide oxygen. You're going to need to ventilate that patient, and you're going to need to do CPR. Okay, you'll have to do CPR. So high flow O2 with a BVM because we're providing assisted ventilations, and we're doing compressions. That's your 0 to 3. 4 to 7 is kind of midway, a little bit better. I'm not doing compressions or anything like that, but I need to stimulate this baby a little bit more, stimulate them, rub on their back, flick their feet, things like that, right? We do not hang them upside down by their leg and smack them on the butt, okay? I know we hear that sometimes, people laugh and, you might see it in a movie. We do not do that. Okay, so wrap them up in your blanket, stimulate them, right? Rub on their back and things like that. And give them oxygen, high flow O2. We're not assisting ventilations here. We're just giving them oxygen. And you can give them what we call blow-by oxygen, where you put a pediatric non-rebreather close to their face with the oxygen running. And basically, if it's close to their face, then it's the oxygen is blowing across their face and they're able to breathe it in. Okay, so blow-by oxygen is something that sometimes we have to do, especially with our kids or anyone that doesn't like to tolerate that mask on them. Sometimes you can just kind of hold it next to their face, and they're still getting that high flow of oxygen. Now, if you have a score of 8 to 10, that's really great. That's really great, and so you're just doing routine care at that point of a newborn. Which, remember, that routine care is keeping them warm, drying them off, suctioning if needed, things like that, right? That we've already discussed. So 0 to 3, if they're too low, then we're doing CPR, assisting ventilations with high flow O2 with a BVM. Okay. If it's 4 to 7, kind of that mid-grade, then we're stimulating them and giving them oxygen. But if they're 8 to 10, then that's just the routine care of your newborn. So number 9, metabolic rate, the problems that can occur because of the metabolic rates of your kids. So kiddos, infants and children have a much faster metabolic rate than an adult, okay? They actually use oxygen and glucose 2 to 3 times faster than an adult. And so that puts them at a much higher risk for hypoglycemia, okay? A couple other things, they have poor glucose stores, right? Because as an adult, remember, if we don't eat, if we skip a meal, then we have that glucagon that's in our liver that our liver can release, and it can be broken down into glucose to be used by our body. Well, kiddos and newborns don't have this. They either don't have it or it's not as good of a store as needed. So they have poor glucose stores, and they have a poor ability or lack of ability to stimulate the release of those stores. With the increase of metabolism, like I said, they use oxygen and glucose 2 to 3 times faster than adults. Then that also adds to the risk for hypoglycemia. Kids also have a higher oxygen demand. Okay, so just being aware of all that stuff is very, very important. Okay. Aerobic versus anaerobic metabolism. Okay. Let me see here. Let me find my notes on this one. Okay. So aerobic metabolism is the process in which your body generates energy, which is the ATP or the adenosine or adenotriphosphate, right? Adenosine triphosphate, when we use oxygen. So we're utilizing oxygen, the process which utilizes oxygen to help generate energy. We're breaking down carbs, we're breaking down fats and proteins and things like that with oxygen. The byproducts of aerobic metabolism are carbon dioxide and water and heat, okay, which is what we breathe off on a regular basis. Anaerobic metabolism is the same production of energy, but without the use of oxygen, or if oxygen is in a limited supply. Okay, so when you're in anaerobic, when you have anaerobic metabolism, you're going to produce less energy, and the byproducts are carbon dioxide, but also lactic acid. Okay, let's see here. It's going to utilize glycolysis, break down the body's stored glycogen, things like that. Okay. So aerobic metabolism is the use of oxygen to produce energy. Anaerobic is the production of energy without oxygen, or if the oxygen levels are extremely limited. Okay, and you find yourself in anaerobic metabolism if you are pushing yourself in a workout and really, really pushing yourself, and you're, maybe you're pushing your body a little bit beyond its normal limits. You'll find yourself in anaerobic metabolism. Okay. Signs and symptoms of child abuse. What behavioral characteristics do you look for? Okay, so child abuse is terrible. All right, just flat out, it's terrible. If you ever find, let me see here. Where are my notes on this? Here it is. Okay, so if you're okay, kids normally, when they're growing up, if you have an active kiddo, then they're going to have injuries, right? They may have a broken bone. They may have bruises and things like that from falling down and playing outside and running around and all that kind of stuff, right? But sometimes the injury patterns can be kind of peculiar, and sometimes the story from the parents doesn't make sense, or the parents or guardian, doesn't have to be the parents, but the guardian or the caregiver, it doesn't make sense, or it doesn't really match the injury pattern, right? So you could have, we talk about like bilateral fractures. Okay, so if they broke both of their arms in the same place, or if there's any burns are a big one. Like it's called dipping injuries, where it's like the child may have been dipped down into boiling water. Okay, and so the burn is on both lower extremities and all the way up, and it stops at the same point. Those are not normal injuries for a kiddo to have, right? Or other dipping injuries could be the buttocks, right? If the kiddo was set down into boiling water, on their rear end. Cigarette burns. We talk about bruises of varying degrees of, oh gosh, what's the word? Just lost it. Healing. There you go. Sorry. Bruises of various stages of healing. But like I said before, you can have kids that are super, super active. So you also have to how is the kiddo acting, right? How does the kid act when they're around the parents or the caregivers or the guardians? Okay. If it's a happy kiddo that, is totally fine with the caregivers being in the room, shows no fear, no anxiety, no nothing like that, then it's probably just normal injuries, right? But if you just kind of get a feeling that this just doesn't make sense, or it's not adding up, or this kiddo is not acting comfortable with their caregiver, then those are all things that you have to really pay attention to. Okay. Injuries that are just unexplainable, or things that don't make sense, or if the kid's story is different than the parent's story or the guardian's, story, right? Signs of neglect can also be abuse. Okay, it doesn't have to just be physical, but signs of neglect, lack of hygiene, lack of necessities for the kiddo in the home. If they are, just think about those things. Okay, so if you ever suspect abuse, the first thing you do is you do not approach or basically share those feelings or suspicions with the caregiver. Absolutely do not do that, because that's just gonna make it worse, right? They're probably gonna ask you to leave, and then you won't be able to care for the child, right? So if you ever suspect child abuse, try your best to get that kiddo to be transported to the hospital. You want to get them out of the environment, and then you relay your suspicions to the nurses and the hospital staff at the hospital. Okay. If you do have to get PD involved, try and do so discreetly. But your number one goal is to get that kiddo out of that environment and to the hospital where they can be, one, treated for any kind of injuries, and two, taken out of that environment and hopefully get found in a better environment. Okay. Okay. Pediatric assessment triangle. So we've kind of talked about this a little bit already, not necessarily the PAT, the pediatric assessment triangle, but when we talk about that initial patient assessment view from the door, it's very similar to the PAT, okay? So that pediatric assessment triangle, let's pull up a picture of this. If I can spell pediatric assessment triangle. There we go. Okay. This is a great picture. Great picture. So here's our triangle. On one side, we've got the appearance. On another, we have the work of breathing, and another we have circulation. Okay. So that should look familiar to you, right? As things that we look at from that initial view from the door. But this is something that we absolutely use with all of our pediatric patients, because sometimes they can't communicate as well as adults, right? They can't use their words sometimes. So we have to really rely upon how do they look, really rely upon the signs that they're showing us, right? So appearance, these are some things that might be problems, like loss of consciousness or level, just if they have a deteriorated or lower level of consciousness. We're looking at their muscle tone. We're looking at their degree of interaction. Do they interact with you when you walk in the door? Are they playing with someone else when you walk in, right? Do they have an abnormal look or gaze, right? They're just kind of gazing off to the side. Abnormal speech or abnormal cry. Are they irritable or inconsolable? Okay, so we're thinking about neuro. We're looking at their appearance and we're thinking about their neuro and their central nervous system. For work of breathing, obviously, we're thinking about respiratory, right? So are they tachypnic? Are they placing themselves in a certain position, like the tripod position, right? Do they have abnormal airway sounds like stridor or grunting or wheezing, right? Do they have accessory muscle use? Are they doing that head bobbing? Remember, we talked about signs of inadequate breathing is that head bobbing with every breath. And what about the nasal flaring? Okay, so that's going to be your respiratory. And then circulation to the skin. What does the skin look like? What's their skin color? Does it have that good, rich tone to their color? Do they look pale? Do they look cyanotic, ashen, mottled, right? Are they diaphoretic? Are they cool? Are they warm? Well, cool or warm, sorry, that's kind of, that's not the view from the door. But are they diaphoretic? And we can also look at their mucous membranes, because their mucous membranes will help us, to see if they look more pale. So if you're thinking about all three of these, if all three of these are okay, then your patient's stable, right? That's what this pediatric assessment triangle is kind of making you think about, okay? If you've got skin issues, then it's most likely shock. If you've got skin and neuro, then it's absolutely shock. And you might have some respiratory in there. But if it's skin and neuro, shock. Okay? If it's only respiratory and their neuro and skin looks good, then it's respiratory distress. Okay? If it's respiratory and neuro, then it's respiratory failure. If they're also cyanotic, and you're thinking that this is the big cause, then that's also failure, right? If it's only neuro, then central nervous system, maybe it's a metabolic order or disorder like diabetes. Maybe they have, maybe a tumor or some kind of formation in their brain, right? Something that's strictly central nervous system. And then if all three are involved, if all three are inadequate or not good, then you've got full system cardiopulmonary failure. So this is just something to think about, right? And you can use this not just for pediatrics. You can use this for the initial patient assessment view from the door for anybody, okay? There's nothing wrong with that. And we've kind of talked about that already. But this is that view from the door. What do you see? What do you hear? Are they exhibiting any signs of distress? And if you need to utilize the parents or the caregiver, then do so, right? Is this, ask the caregiver, is this the child's normal behavior, normal presentation, normal baseline behavior, right? That's your pediatric assessment trial. Okay, so appearance, which is your neuro, work of breathing, which is your respiratory, and then skin, which is your circulation. We've kind of talked about all of that. So now let's go back and talk about the different changes that occur to a mother during pregnancy, okay? Because there's quite a bit, all right? There's quite a bit. So I'm not going to necessarily, I think your book goes over first, second, and third a little bit better, but I'm going to go over like respiratory versus cardiac versus GI and GU, and then I'll make sure and tell you, certain things that are in different trimesters. But when you're talking about your respiratory, the mother's respiratory system, her oxygen demand will increase, right? She's growing things. She's working double time here, and her oxygen demand is going to increase as that fetus continues to grow. Then her diaphragm is actually going to be displaced. It's going to be displaced more superiorly from the uterus that's growing, right? And that's going to lead to decreased tidal volume, because if her diaphragm is kind of pushed up superiorly into her thoracic cavity a little bit, or it compresses her thoracic cavity, think of it that way, then yeah, her tidal volume is going to be decreased. She's going to be breathing more shallowly. And so therefore her respiratory rate will increase to compensate for that, right? To maintain her minute volume. Her oxygen consumption will increase by like 20%, but her respiratory reserves are going to decrease. And so she's not going to be able to compensate as well when she's in times of respiratory distress. Okay. So I would say, when as you're getting into the second and third trimester, you're really going to start to see that tidal volume diminish and that respiratory rate increase, because as that uterus grows and grows and grows, it's going to displace that diaphragm. Okay. And she's not going to be able to compensate as well if she's in respiratory distress. Now, when we're talking about the cardiovascular system, her overall blood volume is going to increase, right? And those of us who are not pregnant, we have about 5, possibly up to 6 liters of blood. That's on average what we have, right? Like average of 5, okay? Her blood volume is going to increase quite a bit. And she's going to have, because she has to perfuse the uterus and the fetus, okay? So if her blood volume increases, her cardiac output will increase. Her heart rate will increase by about 10 to 20 beats per minute. So she's going to be her normal is going to be a little tachycardic. Her red blood cells will also increase. She's going to need more iron. And so, those prenatal vitamins and that kind of stuff is super important. Because the red blood cells, the amount of red blood cells is increasing in our body. Okay, so those prenatal vitamins are needed to prevent anemia, things like that. And her clotting factors, or her ability to clot, is going to increase as she prepares for delivery. Okay, because unfortunately, when delivery does occur, there is tearing and stuff like that, and so her body is basically preparing for that and being able to clot faster. When we're talking about her blood pressure will slightly decrease in the first and second trimester, but it will normalize in the third. Okay, because remember, her heart rate increases, so her blood pressure is going to go down just a smidge in the first and second trimester, and that's okay. But it'll normalize in the third. What we don't want is hypertension, remember, because that leads to preeclampsia and eclampsia and problems. So we don't want hyper. And then if you're talking about her gastrointestinal and genitourinary systems, nausea, vomiting, right? That's the big one. That's the most common in the trimester, and I'm sorry, in the first trimester. However, a lot of people experience it throughout their pregnancy. Bloating and constipation may occur because she's going to have a decrease in peristalsis, right? And peristalsis is the movement of food after you've ingested it, right? It's the movement and absorption of food through your digestive tract, right? So it's going to decrease, and so she'll feel constipated. Her urinary bladder is going to be displaced. It's going to be shifted more superior and anteriorly. So it's going to go up and more forward, up and out. And it's going to be kind of no longer cradled within that pelvic cavity. It's going to be more forward. And so it'll be more susceptible to trauma, right? Especially like from seatbelts and things like that. Okay, more susceptible to trauma. And then her renal blood flow, to her kidneys will increase. And so the kidney filtration will increase as well. Okay, so she's going to need more oxygen. She's going to use more oxygen, so she's going to need more oxygen. She's going to have, decreased respiratory reserves. Her tidal volume is going to decrease, and her respiratory rate is going to go up because her diaphragm is displaced by the growing uterus. Okay, her blood volume increases to perfuse everything else. Her cardiac output increases. Her heart rate increases. Her blood pressure will slightly decrease and then normalize in the third. She's going to clot a lot faster, but that also leads to other problems, right? And then her gastrointestinal, you got that nausea, vomiting, and constipation, and the bladder is going to be displaced because of the growth of the uterus. So you got a lot of things, okay? What are ways to determine the blood pressure of a child for their age group? Okay, so there's a couple of things. One, there's a formula, and I will actually pull up the formula for you. There's a formula to, let's see here, formula for pediatric blood pressure. There we go. This one right here. So your systolic blood pressure for your pediatrics, this is what we want them to have for a systolic, okay? This is normally for any kids age 1 up to about 10 or so. You're going to take 90 and you're going to add 2 plus 2 times their age. So if you have a 6-year-old, 2 times 6, that's 12, plus 90, so that's 102. That's what you want your systolic to be, is 102. Okay. If you have a 3-year-old, then it's 2 times 3 is 6, plus 90, so 96. Okay. Is order of operations. So you always do this parentheses first. So 90 plus 2 times their years and age. That's what you want their systolic to be. If you have a patient who has a systolic of less than 70 plus 2 times their years and age, then that is hypotensive, definitely. Okay. Definitely. So that hypotension formula, again, for kids 1 to 10, is if you have 70, if it's less than 70 plus 2 times their years and age. So 90 plus 2 times their years and age is the normal one we want. We want it close to that as possible. But if it's less than 70 plus 2 times their years and age, then that's hypotension, and that's a problem. And this formula is really helpful because remember, when you have your kiddos, I mean, here, look at it right here. It's really hard to memorize all this stuff, and again, every kiddo is going to be a little bit different. Okay. Systolic blood pressure, diastolic. Remember, your systolic is what's going to tell us, the perfusion and stuff like that. So knowing that, the younger they are, the faster their heart rate is, the younger they are, the lower their blood pressure, and the younger they are, the faster their respiratory rate is. That's a very good generalized knowledge. But when it comes to taking blood pressures and all that kind of stuff, using those formulas will be very helpful as well. You also can use, if you have one of these, and you probably will, based upon where you work, a Broslo tape or a Pedia tape. And it's this little, it's kind of this accordion shaped thing that you put, this says red to head, right? So you put one end at the head and you're basically measuring them. And wherever their foot ends in whatever color scheme, then that's going to tell you the approximate weight of your patient. This is one side, but it'll tell you the approximate weight of your patient. Like, here we go. This one's actually better. You can see how got 9 kilograms, 10, 11, things like that. So the approximate weight, and one side is going to go over, the normal vitals of kiddos who would fall in that weight range. There's equipment sizes for different equipment pieces that you might use. Medications, especially if you're in your advanced EMS, like advanced EMT or paramedic, what are some of your first line cardiac meds and things like that. But that is what these Brasso tapes will show you. So they help you with estimating your patient's weight and also with, the normal vitals based upon that estimated weight. Just got to measure them. Lay them down flat, just like this. Lay them down flat. Red to head, red here. Foot ends right here. That's your approximate. So it's really very helpful. Okay. All right. Let's see here. Before we move on, there's just a couple of these questions left. So we're just going to stop briefly at 14. And before we move on to 15, I know